And with that, we can imagine a very warm welcome from everyone attending, and I'll give you the floor, Dr. Silverstein. Thank you so much for
Thank
coming in.
you. Thank you. Thank you. Welcome, everybody. Good morning. Like Darian said, I'm a clinical neurophysiologist, and I'm talk to everybody about neurophysiological monitoring and basically the prognostic value of what we bring to the operating room. I do have a disclosure; it's not relevant to this talk. So, what exactly is intraoperative monitoring? So, intraoperative monitoring is a subset of clinical neurophysiology. And it really stems from neurology and the tests that we do in a clinic to diagnose diseases of muscles and nerves, and basically brought into the operating room to essentially do a battery of tests to ensure that the nervous system remains intact during a surgical procedure. So the role of neuromonitoring is to continuously monitor the function of the nervous system while a patient is under anesthesia. The surgeon can see the anatomy, they can see what they're looking at. My role is to be able to tell them how the nervous system is functioning under stress. Another role of neuromonitoring is to map um, nervous structures, to help identify different structures in space, to allow the surgeons to effectively know where things that are important that control, motor, output or sensory input, kind of know where those things live within the body, because it's not as straightforward as what textbooks, show you. When you open textbook and you look at the motor system, you look at the sensory systems, it's not as pretty when you are actually working on a patient. So we're able to identify different nervous structures, eloquent areas of the brain, peripheral nerves down in the periphery, and give the surgeon an idea of where these nerves are, and then again, continuously monitor the nervous system during the procedure. And the idea is to have an early warning to predict and then prevent iatrogenic injury to the nervous system. Essentially, want the patients waking up how they came in. We don't want them waking up with new deficits. And if they do wake up with a new deficit, we're hoping that the neuromonitoring can guide the decision making to help prognosticate postoperative management. So the different types of neuromonitoring that are used, like I said, it's a battery of tests that we do. So it's a multimodal approach or a multimodality approach. So we don't just do one test to evaluate the nervous system. We do, again, a battery of tests. We look at the gross sensory system using somatosensory evoked potentials. We look at the gross motor system using motor evoked potentials. Those are kind of our top main modalities. And then we have a bunch of other modalities that we use within that. Basically, we're assessing the gross motor and gross sensory systems. Now, a sensory evoked potential, the way that it works is we stimulate a peripheral nerve, and you can see that in the cartoon here in the animation. We stimulate a sensory nerve, and we place electrodes along the pathway of that nerve. And what we're doing is recording the sum of the action potentials of the sensory nerve. So every time the impulse passes under one of our electrodes at different points along this pathway, we get an action potential on a computer screen. And that's how we're able to assess the sensory nervous system. The motor system, basically, we put electrodes in different muscles, and it's the opposite. We stimulate the cortical area, whether it's through the scalp or directly on the brain itself, and we stimulate and we record an action potential from muscles that we put electrodes in to evaluate. So basically, we're looking at kind of this back and forth highway throughout the surgical procedure. So what are some of the applications that we use neuromonitoring? It's used in a wide array of surgeries: spine surgery, intracranial surgery, vascular cardiac procedures, peripheral nerve surgeries. And the idea is that when done correctly and in a team environment, it can help mitigate postoperative deficits and definitely help prognosticate how the patients will end up being. It enhances our surgical safety because it's real time. I'm able to tell a surgeon that they're getting too close to a structure and maybe they should, move away and work in a different area. And the idea behind that is to limit the stress on the nervous system that's happening while a patient's under anesthesia. And the prognostic value of this is that basically the way the monitoring ends at the cessation of the procedure, we can predict how that patient's going to wake up. Now, there are false positives and false negatives that can occur, and I'll get into some of that. But essentially, when everything is done correctly, if the nervous system is intact at the end of the procedure electrically, from what I'm seeing on my computer screen, the patients typically wake up neurologically intact. If there is a change to that data during the procedure and then we can't get it to recover, and then those patients typically wake up with some type of deficit. And there's a ton of literature that supports this, including our own literature that supports the prognostic value of neuromonitoring and the increased safety of using different, multimodal approach to identifying nervous system depression during surgeries. So just to talk more about that prognostic value of intraoperative neurophysiological monitoring, so IONM, in surgical outcomes. Why does the nervous system react the way it does? Well, it's under stress during surgery. And it's under stress whether it's because of frank trauma or it's under stress because there's retractors being placed and we're pushing tissue out of the way. And this stress to nervous tissue can cause changes in electrical activity. And what we see is changes to our what we see on our basically our computer screen. And it usually is a decrease in amplitude or an increase in latency of the response itself. And it's important that we do this continuously. So we're constantly, so when we're monitoring throughout a procedure, we're doing continuous testing of the nervous system. And by doing continuous testing, we can be timely, and if there is a change to the nervous system, we can intervene as soon as we see it. So there's as little delay as possible, because the quicker that we intervene, the quicker there can be to recovery. The longer we wait to intervene, the more stress the nervous system is under at that point, the longer it may take to recover, or it may not recover at all. So it really comes down to being timely, uh, as timely as we can be. Now, we can't always do every test continuously, and there's limitations, which I'm not going to get into. It's kind of out of the scope of this lecture. But just to say that the idea is that we want to be as proactive, as focused as possible. Now, changes to the neuromonitoring data, like I said, have a lot of prognostic value, because if the nervous system's intact at the end of the procedure electrically, these patients wake up typically intact. If the nervous system has changes during the surgery that don't recover or don't recover fully, then they have to be managed differently postoperatively, because they could have transient deficits, they can have permanent deficits. And a transient deficit is a deficit that recovers, but it's still a deficit, and it still has to be managed in the post-op setting by the surgical team and by the medical teams. So what are some of the predictive capabilities for neurological deficits? Well, the changes that we're looking for typically are amplitude reductions in our waveforms. So when we're looking at waveforms and we're looking at the sum of an action potential of many cortical neurons and many sensory neurons, basically any kind of reduction in amplitude could be an imminent warning that something's happening to the nervous system, that there's some type of conduction block or something's happening to the nervous system that's causing stress. There's also, as I mentioned a little earlier, latency. So latency is the time that the time it takes from stimulation to the point of where we see the waveform begin. If that latency starts to become prolonged over time, then what happens is then there's a change to the nervous system, and the nervous system ends up being uh, becomes a little weaker because of this prolonged latency, but really amplitude reduction is really what we're focused on. Now, these changes can help predict postoperative neurological deficits. And when we have these changes, and again, being timely and prompt, we're able to alert the surgical team who can then make intraoperative decisions to either hopefully reverse the change or at least not make it any worse. So, for example, when you're looking at this screen here, and I appreciate that um, probably everybody on here probably doesn't know what they're looking at here, but just to make it really simple, this black line here, this kind of going straight down, this is a hand motor potential. And these are what they look like. And then in this, where I boxed out in red, there's a significant decrease in the amplitude to the point where it goes away at one point, and then it returns. So what happened in this surgery, where we were doing an intracranial procedure, and the surgeon got very close to the white matter tracts, and we were able to tell him, okay, the white matter tract is stunned now. And what they did was they stopped working in this area. And by stopping the work in this area, we were able to get a recovery, and this patient woke up completely intact. So we were able to give a prompt intervention into a potentially devastating injury. If we didn't reverse this patient would have woken up with a paralyzed limb, essentially because the entire upper extremity went away here. I'm focusing on the hand here. It was the entire upper extremity that became weak. So it would have been a major weakness to this patient if we would have left it as is. But we were able to reverse it, came back to baseline here. These are nicely formed responses, and the patient woke up fine. That's kind of our role in these procedures. So there's a lot of evidence that supports neuromonitoring. And there's more and more literature supporting the prognostic value of neuromonitoring. Neuromonitoring has an extremely high specificity rate, between 90 to 100%, meaning if you have a response and the response goes away, the likelihood of that patient waking up with a deficit is extremely high. So high accuracy. It has a mid to high sensitivity. And that really depends on the tests that we're running. Not every test monitors for every deficit. So for example, you could have motor changes that are not detected by the sensory tests. So that would, limit the sensitivity of our sensory tests, for example. Or you can have changes to your autonomic nervous system, which we're not monitoring. We're monitoring somatic nervous system. So those changes we never see changes in those types of cases. The autonomic nervous system is in fact disrupted, and those patients would wake up with a deficit that we didn't detect. So the sensitivity is mid to high here. So let's look at some cases to show kind of the value of neuromonitoring from a case-by-case level. So the first case I'm going to share with you is a spine case. It's an extension of a fusion from T5 to T12. It's a reduction of a fracture and kyphosis. So it's a deformity procedure. 73-year-old female who essentially has bilateral lower extremity pain, a slew of underlying medical issues. They've had multiple spine surgeries, but they have an intact motor exam, 5 out of 5 essentially in all of their lower extremity muscles. And they have some kind of non-dermatomal sensory loss. Now, they did have a spinal cord stimulator placed, which is going to be important to this specific case study. Now, this case I did probably 10 or 15 years ago, so before the advent of MRI-compatible spinal cord stimulators. But looking at this medical history, I'm coming into this thinking, I might not get sensory potentials, but I should have motor potentials. And the reason why I might not get sensory potentials is because of these metabolic issues tend to attack the nervous system. Raynaud's syndrome, which is a microvascular issue, diabetes, which causes peripheral neuropathy, things like this, hypertension, all affect the nervous system, and because of that, they affect typically the sensory system first. So a lot of times I see a history like this, and I go into it thinking I might not get sensory baselines, but I should get motor, because very rarely do these affect motor potentials until it's like late end stage type neuropathy where the motor gets affected. But the fact that the patient had a motor exam 5 out of 5, we should have gotten motor potentials here. So what you're looking at here is basically our sensory potentials over here and our motor potentials over here. And we didn't have any sensory potentials. But again, um, we chalked this up to the patient's underlying medical history. But what didn't sit right with us was we didn't have any lower extremity motor potentials from this patient, which you can see these are completely flat. So here's a hand. This is a control here. That's the little blip there. That's the hand motor. These are flat going across the top here. You can see iliopsoas, your quadricep, and your tibialis anterior muscles. These are all lower extremity muscles. There's nothing there, so no motors. And it's bilaterally no motors. And this didn't really make sense. And this, so what we're doing, so in this procedure, the patient's going to be placed in a prone position. But before that, we do a pre-position baseline. So we get the baseline while they're in a supine position. So they're lying on the OR stretcher before they're on the operating room table. And because this didn't make any sense to us, the surgeon wasn't comfortable moving forward with the procedure because we felt something was happening within the spinal cord. Um, that we didn't know about. And we didn't have an updated MRI in this case because we had a spinal cord stimulator in and the patient couldn't get an MRI. So we had no new MRI to base on. So we started to prep the patient to wake them up to do what we call the wake up test to see if they were truly paralyzed or not at this point. And what we did before we did that was we brought the patient into a seated position in a more flexed position. When we did that, what you can see is a little bit of a response comes in from the lower extremity here, right there. And then we extended the patient back again. So we lied them down again and the response went away, sat them back up and the response came in. So what this is telling us is this is a positionally induced change. So every time we extended the patient, they lose function in their legs. And it happened bilaterally. So nothing here, and then the response would come in and then would drop again and then come back. So the surgeon decided to abort the procedure, needed to get an MRI of this patient, see what was going on in the spinal cord, but needed to get that spinal cord stimulator out. So what we did was a couple of days later, came in, the surgeon did put the patient in a lateral position, kept them kyphotic, and kept them awake, and took the spinal cord stimulator out. So here's a spinal cord stimulator that needed to be removed. So we got that out, and we came back a few weeks later to do the procedure again. Now that we knew that we got an MRI and showed this big herniation at T11, 12. So what was happening was every time this patient extended, this would buckle into the spinal cord, and they would lose all their function, all their motor function in lower extremities. So we asked the patient, when they came back, we asked them, when you lie down at night, do you ever lose, your ability to move your legs? And interesting, the patient goes, "Oh, I never lie down. I sleep in a chair. I sleep upright because every time I lie down, I can't move my legs." So it correlated clinically to what we were seeing electrically, and the fact that intraoperative monitoring, we kind of have to be like detectives when we have these changes or these signals, these baselines don't make sense to us. We have to really question everything that's happening. So even though this patient had 5 out of 5, she has 5 out of 5 in this position, but every time we extended her, we would lose it. Knowing this, we were able to come back a few weeks later, do the procedure, kept her in a position where we can get her as extended as possible without losing signals. And we were able to come in and get these beautiful motors from her lower extremities, as seen here. And we actually got sensories too. So even though we chalked up the sensories to potentially underlying medical problems, that wasn't the case. It was all positioning induced. So here, neuromonitoring guided more kind of detective work from the surgeon standpoint to figure out what was happening with the patient. And we were able to actually do this beautiful correction a few weeks later, and the patient was doing great. The next case is a pterional craniotomy for sphenoid wing meningioma. Here's that tumor. So this is a right-sided approach. So we're going to come in from the right side to the tumor. 54-year-old female had a seizure. They have this significant tumor. It's, again, right-sided approach. And when we do craniotomies, a lot of the monitoring that we do is lateralized to the other side of the body, right? So if they're doing a right-sided craniotomy, we're focusing on the left side of the body, and that becomes important in this procedure. Now we still monitor the ipsilateral side because, especially when you have a bilateral tumor like this, but also for control purposes. In this case, what you're looking at here is motor vote potentials, and you're seeing it's the entire case. It's a trend over time from the top to the bottom is the beginning of the case to the end of the case, and you're seeing the motor vote potentials from the upper extremities on the left, and the lower extremities on the left, and the right upper extremities and the right lower extremities. During the procedure, there was a copious amount of bleeding, and the surgeon didn't know where the bleeding was coming from. We knew a vessel was bleeding, but we didn't know which vessel it was and how devastating it potentially could be. So while they were trying to control the bleeding, we lost our ipsilateral, so our right-sided lower extremity motors, which are circled in red here. So this was able to guide the we figured out based on this change, which vessel was being affected. So this was something that was perfusing the um the left brain, the portion of the left brain that controls the lower extremity. So this is going to be your anterior cerebral artery complex. So contralateral to where this, so this is a right-sided craniotomy. We were able, based on the neuromonitoring change, we were able to figure out that it was the contralateral anterior cerebral artery complex that was disrupted, that was bleeding. And once we knew that, we knew which vessel it was, the surgeons were able to target that vessel, go in there, get an aneurysm clip on it to stop the bleeding, trap the vessel, and we were able to get some recovery here. And this patient, it kind of had um, a wax and wane effect on the motor potential. And they did wake up weak, but they got better over time. So they woke up with a transient weakness. But what the change to the neuromonitoring data did was allow the surgeon to know which vessel to target and to essentially mitigate a devastating paralysis of the lower extremity. So they were able to get. You can see here's a clip on the contralateral A2, which is anterior cerebral artery, and then showing perfusion postoperatively to that, with collateral um, uh, perfusion. So another case study, this is a microvascular decompression for hemifacial spasm, a 62-year-old female. They've had spatial spasms for 20 plus years, no relevant medical history. So, I've been talking about some of the prognostic and the guidance tools that neuromonitoring can provide in surgery. Here, we also do mapping of different nerves to identify nerves. So again, when you open up a textbook, and it tells you what the nerve is, and it has a little diagram and says, okay, this is the facial nerve, or this is the vestibular cochlear nerve. So the facial nerve is cranial nerve 7, and the vestibular cochlear nerve is cranial nerve 8. They typically live within a complex in the cerebellar pontine angle, or the CPA. So what you're looking at here is this is a cranial nerve, either cranial nerve 7 or cranial nerve 8. This here is what we call an electrified ring dissector. So I'm delivering current through this tool, and the surgeon's using it to identify nerves. He can also use it to peel tumor and to move things out of the way. But essentially, there's electricity going through here at a low rate, 0.1 to 0.5 milliamps. And what you're looking at here, this is my screen, and these are facial nerve muscles. So we're stimulating this between 0.1 and 0.5, and we're not getting any responses from the facial nerve. And the surgeon's like, well, I believe this is the facial nerve. And what this is telling us is number one, not the facial nerve, because and this is obviously assuming that there's no technical problems, and we're going to assume that there's no technical problems. But basically, because these nerves live very close to one another, I had asked the surgeon to kind of wrap around the nerve and see if maybe the facial nerve itself was on the other side of it. And when we did that, as we got to the other side, we were able to get beautiful evoked responses from the facial nerve at 0.1 milliamps. So what that tells us is what you're actually looking at here is cranial nerve 8. Cranial nerve 8 is a strictly sensory nerve. So of course, if we stimulate it, we're not going to see muscle activity from it, but cranial nerve 7 was living on the other side of it. So the neuromonitoring and the neural mapping helped guide the surgeon to where the nerve actually lived, and from there he can decide how he wants to position himself to get that nerve out of the way or find the vessel. In the case like this, you want to find the vessel that's offending the facial nerve. Another thing that we do in MVDs for hemifacial spasm specifically is there is this phenomenon known as the abnormal muscle response, and this only happens in patients with hemifacial spasm, and essentially it's an electrical anomaly. You stimulate a branch of the facial nerve, and you're supposed to get a motor response from the muscle that you're targeting. So if I stimulate my facial nerve here, I should get a motor response from my oculi muscle, which is what you see here. But patients with hemifacial spasm also get a late response from a completely different muscle group. It's called the abnormal muscle response. It's a backfiring of the facial nerve motonucleus. But in hemifacial spasm, when the offending vessel is taken off of the nerve, this response should go away. And if it goes away, and it's the only test that we do, that you can tell the surgeon you have just cured this patient, at least in the immediate post-op phase. You have just cured this patient of hemifacial spasm because the abnormal muscle recording only happens in patients with hemifacial spasm. If you try to do this test on yourself and you don't have hemifacial spasm, you would never get this abnormal muscle recording. And what you're seeing here, here's that abnormal muscle recording. And then when the offending vessel is taken off of the nerve, you can see it completely flatlines. So you're able to tell the surgeon and basically diagnose that the patient is going to be completely hemifacial spasm free, at least in the immediate post-op phase. Long term, that's debatable, but immediately and for a little while, they'll be completely free of the hemifacial spasm when that abnormal muscle recording goes away and that motor response stays intact. So another case study, lateral lumbar interbody fusions. These are spine surgeries that go through the psoas muscle. The lumbar plexus lives within the psoas muscle. So as a neurophysiologist, I don't approach a lateral lumbar interbody fusion as I don't approach it as a spine surgery. For me, it's peripheral nerve surgery because I'm worried about the obturator nerve. I'm worried about the femoral nerve. You can see in this image here that what happens is a retractor is placed and open. So it's a fixed retractor that's placed and open. And the femoral nerve, the fully formed femoral nerve, actually traverses the L4-5 disc space. And what happens is when you open that retractor, that femoral nerve gets pushed back, potentially stretched or compressed against the transverse process at L5. And if that happens, you have essentially a conduction block or a loss of perfusion to the nerve, and you should see changes to the evoked potential data. Now, in these cases, we do map the corridor to find where the nerves live, but only thing mapping does is tell you where nerves are in space. It doesn't tell you the continuity of the nerve. And that's where you need the evoked potential, the sensory evoked potentials and the motor evoked potentials to tell you how that nerve is functioning, especially under a tensile force, such as a fixed retractor. Because remember, the retractor itself, it's not deviating. So it's putting on this tensile force, and nerves can only handle so much stress. So what you're looking at here is a waterfall of sensory evoked potentials from the femoral nerve and motor evoked potentials targeting femoral nerve innervated muscle. So quadricep motor evoked potentials from the beginning of the case to the end of the case. And what you see in red is an isolated, and remember, these are lateralized surgeries. They're coming in from one side. So we have a left and a right. The right side ends up being our control side. You can see a complete flat line here, the sensory response, and a complete flat line of the motor response. So the nerve became essentially ischemic due to either a stretch or compression. And because of that, we intervened. And as soon as we took the retraction off, the responses popped back. And this patient woke up completely intact. But here's another case where they did not pop back. And the reason in this situation why they didn't pop back was unfortunately, our intervention wasn't heeded. So when we alerted the surgeon to the change, they decided to continue on with the procedure. By continuing on with the procedure, they left the the nerve under traction. And because the nerve was under traction for so long, it never recovered. And as you can see at the end of the procedure, there's no responses from the sensory or the motor. And this patient woke up with a complete 0 out of 5 knee extension, a devastating, devastating injury, and sensory disturbances also in their femoral nerve innervated areas. So, what are some of the challenges and limitations in prognostication with neuromonitoring? Well, there are several factors that influence the accuracy of neuromonitoring. One of the biggest things is anesthesia. So, anesthesia, the idea behind anesthesia is to keep the patient asleep, have them not feel anything, have them not move, have them not remember. These are all inhibiting the nervous system. My job is to excite the nervous system. So there has to be a balance of what anesthetics and medications they can use so we can get optimal signals, but at the same time, it's safe for the patient to be under anesthesia where they don't feel anything, they're not moving, and they're not feeling anything, and they don't remember anything. So it's kind of a dance that we have to negotiate and play with the anesthesiologists. Certain modalities that we do are more at risk for being depressed by anesthesia. So it essentially comes down to the amount of synapses within the modality itself. So for example, a sensory evoked potential has about 3 synapses. So while it's affected by anesthesia, it's not as much as, let's say, a motor evoked potential, which has many, many synapses, or a reflex, for example, which has many synapses. So these are polysynaptic or oligosynaptic pathways. And have inputs from other systems as well to create volitional movement. So the more synapses, the more volatile anesthesia is going to be, or more hostile towards the neuromonitoring data. So we have to keep that in mind when we're monitoring. Also, the underlying patient, pathology and their underlying comorbidities also have an effect on whether or not our data is going to be good or not. If they're weak, they have, motor weakness, we're going to have poor motors. And then superimpose anesthesia, it's a confounding effect, which also compounds the issues. So poor underlying comorbidities and anesthesia makes it more difficult for us to get good, reliable responses. And on top of that, we have technical artifacts that we as neurophysiologists have to be very, very aware of. So I'll give you a perfect example. What you're looking at here is a mirror image response. So you have this kind of what we call a negative deflection here, and we have these positive deflections here, and these are supposed to be mirror images of each other. And what this test is doing is looking for where the sensory portion of the brain is versus the motor portion. The sensory portion looks like this, and the motor should look like this. Now, at first glance, this looks like sensory and motor. However, this is actually an artifact. For whatever reason, this is presenting like a motor, but it's not. It's not the motor area, and the reason for that is the latency is not correct. There's a number of issues. I don't want to get into too much of the weeds on this here, but basically there are issues with this that make this an artifact and not real. And you need a trained eye to see that because this looks quickly like like this is motor area, and that would give the surgeon false information and basically would not be good. And it just creates a lot of confusion if you're giving inaccurate information. This is what it looks like when it's true. So this is sensory and this is motor, and this is a correct reversal here. So this right here is sensory cortex, and this right here is motor cortex, and this between here and here is the central sulcus of the brain. So there are potential false positives and false negatives that can occur. False positives arise for multiple reasons. More often or not, motor evoked potentials are more sensitive to having false positives. And the reason why that is because there's a lot more involved in creating a motor evoked potential than just direct cortical spinal neurons. And there's other inputs from the extrapyramidal system, from other descending pathways that create volitional movement. And if those get disrupted during surgery, but your cortical spinal tract doesn't get disrupted, then you lose your motor potential and the patient wakes up completely intact or maybe a little transiently weak, but essentially it's a false positive in the sense that the test itself didn't yield any clinical correlation, um, because there are other things happening. Now, false negatives don't happen as much, especially in spine surgery. You don't really have false negatives. If you have signals in at the end of the procedure, the patients typically wake up intact as long as you have real signals. In brain surgery, it's different because in brain surgery, the stimulation itself can bypass the areas of the brain that are at risk. So, like for example, here this was an aneurysm clipping, and we were looking at two different motor potentials. The top one is what we call a direct cortical motor. This is we put a grid on the brain. We're stimulating the motor cortex directly. Here we're doing transcranial stimulation. So this is going through the scalp and through the skull. Um, so here we have a loss of the motor potential due to a temporary vessel occlusion in the aneurysm. But at the same time, the transcranial motor did not change at all. So this was a false negative because what happened was the transcranial motor was bypassing the cortex and the area that was lacking of perfusion due to temporary vessel occlusion, where the direct cortical was giving us the information that we needed. So this is where there's a lot of redundancy in some of these tests because of the potential for false negatives and false positives for that matter. It's also always important to have a clinical correlation. Any type of neuromonitoring change has to be put into context of what's happening. There are things that happen outside of the surgical field that we also monitor for, or that we can detect. And again, we have to play detective sometimes when that happens, especially when it doesn't make sense to a clinical correlation. For example, you have a lot of times patient positioning, your arm falls asleep, and anybody can relate to this. If you sleep in your arm and your arm goes numb, that is going to manifest electrically as a drop in sensory signal in the operating room. And we're kind of the eyes for the patient to fix that, because we don't want somebody waking up from spine surgery with a paralyzed arm because they were in a position for 7 hours that they couldn't move themselves, right? Because when your arm falls asleep, what happens? You move it and you get rid of that numbness and tingling. But a patient can't do that when they're under general anesthesia. So that's why we're there. But everything has to be taken into clinical context. So what are some of the challenges that we face? Well, whenever you're doing complex neurosurgery, you have complex neurological deficits, and you have variable anatomy, and you have all these underlying factors that can influence whether or not you get good data. So the anesthetic effects, for example, and again, mainly on the polysynaptic and oligosynaptic pathways, your physiological underpinnings. You have to make sure that technically that your leads are placed correctly, that you're testing the right tests for the case, for the procedure, that you're doing the right tests. We have to deal with an extremely hostile electrical environment in the operating room. So electrical magnetic interference is important. Any underlying comorbidities, pathologies, these all confound our responses. Baseline quality is so important. And you have to be honest about baseline quality to the surgeons, because if you have a response that's very, very tiny, the likelihood of that going away is high during the procedure versus a robust response at the beginning of the procedure. And you have to have a buy-in. You have to have teamwork from the surgeons, from the anesthesiologists, from who you're working with, so that when there is a change, that there's an algorithm. There's an algorithm to change it. So, for example, I showed you that case where we, stun the white matter tracks earlier on in this talk, and when we stunned the white matter tracks, the first thing that we do is surgical pause, irrigate to clean out the area, increase the blood pressure, because a lot of times it's a perfusion issues, and then essentially stop working in that area. And what that does is it helps for the recovery. If you keep on going in a traumatized area, it's not going to get better. So there has to be a multidisciplinary approach to this, and a buy-in from the surgeons and the anesthesiologist to make changes. Because as a neurophysiologist, I have no control on whether or not a surgeon wants to continue working in an area that potentially is damaged, and I also have no control over what an anesthesiologist does. So we have to work together to have the right environment to make sure the patient's as safe as possible. So what are some of the future directions and some of the clinical implications of what's going on? Well, I think high resolution monitoring is definitely going to be a thing. There's going to be new technologies that integrate the neural monitoring and the neural mapping with maybe augmented reality and the navigation systems that we're using. We're also going to see more machine learning and AI integration into the neural monitoring data as well. There's going to be real-time integration that allows for really, really complex interpretation. Because right now we're kind of interpreting some of the stuff almost like cavemen, unfortunately. It's based on recognition, it's pattern recognition, it's looking at percentages of drops. I'm hoping that AI and machine learning can help see subtle changes that we can, improve and make, surgery even safer, than it is. And then obviously introducing novel modalities, that things that maybe aren't being monitored. So, for example, we introduced the external urethral sphincter reflex, which we introduced the operating room a few years ago, and this is a redundancy to the bulbocavernosus reflex, but also discreetly monitors the external urethral sphincter and urinary continence. And this is showing that here. So introducing new modalities and bringing in new things is going to increase our sensitivity, it's going to increase our specificity, and it's going to improve, patient outcomes by doing different types of tests that can benefit these patients. So also refining prognostic models with big data. We need, clinical neurophysiology, and especially neurophysiological monitoring, doesn't have a lot of big data, doesn't have a lot of big outcome studies, unfortunately. So you need large clinical data sets that can help prognosticate postoperative deficits, can help prognosticate just postoperative outcomes in general. And then from those big data sets, then you could personalize the risk assessment on that patient to optimize, surgical decisions. This is one of our papers that we published a few years ago. This was actually the largest case series, 121 brain tumor patients that was ever performed, looking at the short and long-term prognostic value of motor vote potentials. And we concluded, while some patients may experience true intraoperative motor structural damage that results in new motor deficits, patients with postoperative deficits that don't have motor vote potential changes usually suffer transient deficits that will resolve over the postoperative course. So just to conclude, I don't know how I'm doing on timing here. I think I'm doing okay. ILM facilitates early detection of neural compromise during surgery, which can help improve patient outcomes. Can also help guide surgeons to provide guidance whether or not they need to change what they're doing. Maybe, try and map an area to see where nerves are, change, the location they're working in, or sometimes abort the procedure altogether if something was on the nervous system that might not be reversible or is reversible, and they don't want to continue going on because they have to continue working in that same area, which would just hurt the patient at that point. And then future research and technology, integrating all of these really, really cool new technologies into what we're doing to make it safer, to make it better, to make interpretation easier. I think it's all great stuff, and it's where we're going. So I want to thank everyone. If anybody has any questions about this field, feel free to, shoot me an email or, however you want to contact me. But I guess, do we have time for questions? Or anybody has any questions? I don't know. This is my fifth year doing Brain Terms. I want to thank Brain Terms and Dr. D'Amico for inviting me. I've been lecturing at this at Brain Terms since the inception, so it's always an honor. So thank you.
Yeah, and thank
Yeah,
you for coming for 5 years now. That's awesome. That was a great talk on something that we don't really know much about. Do you have some questions for or time for questions right now?
yeah, we have that.
One that came in was on like the autonomic nervous system. Is that something you see it developing like modalities for that in the future, or is there just no utility for that, or?
Oh no, that's a great question. There's definitely a utility for it, and it's definitely being worked on. The biggest problem with the autonomic nervous system is the bandwidth of our machines. They the autonomic nervous system is actually recorded in such a low frequency that a lot of our machines can't get that low to record it. So it's really it's an engineering issue currently, but it's going to happen. There are ways there are kind of rudimentary ways to monitor the autonomic nervous system, and we can with somatic stuff we can indirectly in certain situations monitor the autonomic system. Um, as long as it's before any of the autonomic nerves have branched out and they're purely autonomic at that point.
Right, that makes sense. Um, Next one is like, where does neurophysiology sit in its evolution, like in terms of buy-in from surgeons and other people in the OR? Is that ever a problem in terms of buy-in?
Yeah, unfortunately, so neurophysiological monitoring specifically is a multidisciplinary um, discipline. Okay, you have typically the MDs that are involved in it are neurologists. But then you have people doing it that are PhD level, you have bachelor level people, you have people from kind of all over the place, and there's only a few actual schools that have coursework or degrees in neuromonitoring. So, for example, University of Michigan has a bachelor's degree in neuromonitoring through their kinesiology program. University of Connecticut has a master's program now in surgical neurophysiology, and I think there's one other school. I think Carlo University, I think, has a neuromonitoring bachelor's degree in connection with UPMC. Now, because of that, there is a lot of people learn this on the job. So it's on the job training, so to speak. So depending on who's teaching you, unfortunately, can be the difference on whether or not you know what you're doing versus you don't know what you're doing. And if you don't know what you're doing, unfortunately, then the buy-in from the surgeon side is a lot less because they're not going to trust you. And if they don't trust you, and listen, surgeons, are brilliant individuals, but they're surgeons. They're focused on their discipline. They don't want to know what what I'm doing all the time. They want to know that when I'm giving them information, it's actionable, right? But they don't necessarily know clinical neurophysiology. That's not their role. So if they just don't trust you, then they're not going to listen, unfortunately. And that's when patients get hurt, and that's when um, and then the trust falls even further and further and further. So in order to have the buy-in with the team, you have to, show up and do the work every day, but also kind of prove your trust and your worth in that sense by giving information that's actionable so the surgeon can take that and go, okay, when when he says something or when she says something, I should listen because it's going to correlate to something because I've had that happen before. Um, so I think the evolution, I think it's getting better, especially as we get involved in more complex procedures. Um, but we don't have time to get into the weeds of this conversation, but it's also kind of the tail wagging the dog, unfortunately, with regards to the field itself. It blew up in the mid 2000s and covering every single spine surgery that's out there, which is debated whether or not they need to be covered. So what happens is you have a supply and demand issue. Um, Not enough people that are trained to do this and a high demand to monitor. So you're putting people in that maybe shouldn't be in the operating room doing monitoring these cases, and that's where the trust becomes the issue.
Right. That kind of leads into another question we had. You talked about this a little bit, and it's probably like a degree's worth of information, so it's going to be hard to answer. But just could you talk about what goes into making the decision if you want to do the actual monitoring or not? Like you talked about comorbidities, or I'm not sure if like brain region has an impact on if you want to do it or not, or like what goes.
So yeah, so typically so it's not about whether or not we want to do it or not want to do it. Really it comes down to we adjust our monitoring based on the procedure. So essentially what happens, it's a diagnostic tool. It's another tool in a surgeon's toolbox. So he orders it the same way he orders, an outpatient EEG, or, he orders the test. It's on me to know what type of case it is, and then triage it, right? I look at the case, I look at the MRI, I say, okay, this is like for example, today we have an aneurysm clipping that we're monitoring, and it's an A2 aneurysm. So I've already talked to my tech and said, okay, it's day two. We want to focus on lower extremities because we know that the anterior cerebral artery perfuses the part of the brain that controls your lower extremities. So we end up becoming more hyper focused on that. So um, that's the way we kind of triage the cases. Is we look at the type of case it is, and then focus. What are the structures that are at risk? And and each step of the procedure has different times that different structures are at risk, and you know, we have to be able to do that. So it doesn't matter what the case is. If the case is booked based on that case, then we decide what tests are done and what should be appropriate for that case, and what the goal of the surgery is. If the goal of the surgery is um, a gross total resection, then we're going to be as diligent as possible in making sure those pathways are intact for as long as possible, and give as much actual information to the surgeon as possible.
All right, that makes sense. Um, want to hear about, could you speak to the emotional side of like having such an important role in the OR? Um, yeah, just like how you deal with that, or maybe a situation that's come up in the past.
Yeah, that's a great question. I think we're very similar to anesthesiologists and other kind of what I consider ancillary providers. We're not the primary provider for a patient. So I typically meet the patient the day of surgery, and we don't necessarily see them after surgery. We always follow up, but so from an emotional standpoint, it's definitely, emotional if you lose signals and you can't get them back, and there's devastating injury. Um, that's like anything else, it takes a toll, on you. But all we can do is do our best for that patient in that moment, and give the information and give as much help as possible to the surgeon. Unfortunately, a lot of that burden falls to the surgeon, because obviously they're the ones that have to manage that post-operatively, right? They have to talk to the patient's family. They need to deal with the patient. It's a much more emotional burden on the surgeon. I'm not saying that we don't have emotion. I don't want to come off like that, but from a patient standpoint, the surgeons are definitely bearing a lot more of that than we are. But it does take a toll if you lose signals. But unfortunately, it's out of our control, other than the information that we can provide to kind of help guide the best that we can.
Amazing. Well, thank you so much. I think we'll maybe end it there and just have like 3 or 4 minutes to use the bathroom, and then we can jump into our